Sorry. Good morning. I would thank my invitation being with you today, and happy to share with you this issue with the growth plate, the challenges in the post-traumatic physeal injury, and the outline is the history, a little bit of what type of arrest we have, the management options, and the bar resection surgery and literature review. And I didn't help it. So I found this on the internet. So with what's happening in the social media, I just wanted to put it in. So at the end of this lecture, I want you to have these couple of questions to put it in your order. Maybe you can put it the same order or change it. Like what the challenges, either it's an early and accurate diagnosis of physeal arrest, timing and the planning of the surgery, parental counseling, the limited surgical options for the younger children, and the long-term follow-up and the compliance. So let's start with John Hunter. He's the one discovered that the growth is happening through the physes. He developed this through his study in the chicken, growing chicken by injecting a dye. This was before discovering the X-ray, and he's called the father for the growth plate. And the causes for the failure can be ranging from the trauma, the infection, the tumor, radiation, ischemia, or iatrogenic. So when I was preparing this lecture, there is a different spectrum for failure of the physes. So starting from the skiffy up there, or the post-septic where you can have a bar as well, or even the focal fibrocartilaginous dysplasia where they can have the rest of the physes, or the more common to have it on the post-traumatic. And the consequence of the growth plate disruption can vary from either an angular deformity, leg length discrepancy, epiphyseal or joint distortion, or a combination of all of them. So a little bit of history, histology. So we know that the cartilage is avascular, and the epiphyseal and the metaphyseal blood vessels are from the epiphyseal side and the metaphyseal side. And when we have either type 3, Salter and Harris, there's an interruption of the epiphyseal vessel, and maybe there is an injury or hematoma happening there at the physes, or even more in the type 4, where you can have a disruption of the metaphyseal and the epiphyseal vessels. You can have the bar, which is very well described in the Salter and Harris, which is a very well-known part in the classification for the physeal injury, or the less well-known, the Peterson one. And the Parks line, or the Harris-Parks line, are a recoverable or an irreversible arrest of the growth. And by knowing that this line here at the distal metaphysis, that means, and this line is parallel to the epiphysis, that means that this injury is a recoverable, and the body was able to compensate for this injury, which is a different part when you have an physeal bar. This line will be pointing to where the physis is being arrested. So the growth arrest can happen after a trauma. This can be complete, and it will affect the leg length discrepancy. We'll do a leg length difference, or partial. When it's partial, you can have a central part, or a peripheral, or a combined. So let's start with the central one. If you have a central one, you can have an angular deformity if it's an eccentric, and will give you the tenting of the articular surface. And this is what we call the fishtail deformity. It's very common in the supracondylar humerus when you do it. Like in this case, you have this central bar here, and the tenting and distortion of the physis. The peripheral one at the edge, mostly it will affect the angular deformity rather than having a leg length discrepancy. The linear one, which happens in the Salter type 3 and 4, it cannot have a combination if it's a central or a peripheral one. So I try to put it in this way, the A, B, C, D, E, to remember it. So when it's more older, it's better to have a physeal injury because it doesn't have too much growth left. The bone affected, the lower femur is worse, and the central part is more better. It doesn't have much angular deformity if it's central. And the amount of the bar, if it's less than 50%, you can resect after less than 50%, and the post-traumatic is better than the post-infection for sure. And we know it's very important to counsel the parents. When you have a physeal injury, you have to counsel them that after a few months, you can't have the physeal injury or the deformity. Rather, on the opposite side, with the irradiation or infection, it's unpredictable. It can happen anytime. The radiological evaluation from the plain X-ray, it's very important to have the sclerotic bony bridge and the Harris line and tenting in this line with the leg length discrepancy. Some would be preferring for a CAT scan for evaluation for the bar. I would prefer the MRI. And the MRI, the 3D gradient fat suppression, can sometimes be very helpful in detection where the bar is, especially like if you are doing with the Blount disease, or you're a believer in the resection of the bar in the Blount, you can use it as well. So this is the essence of this talk, how to treat the physeal injury. First, to stop the deformity. And after this, make the bone straight. And after this, you can stretch it. If you are smart enough, you can do it in one surgery. Sometimes for myself, I can do it like staged, so I stop and straighten the bone, and after this, I will deal with the leg length discrepancy. So the treatment, first to counsel the parents and tell them how about this physeal injury and the expectation of the parents and knowing how this injury will lead to. Corrective osteotomy, complete epiphysiodesis, guided growth, bar resection, lengthening, combination of everything with all this. What about the bar resection? The bar resection, it can be done if the size is less than 50%. I think 50 is a big number. I think it's less than this, like 25%. More than 2 years is left. And if it's post-infection, avoid if there is a drainage more than 1 year after it. And sometimes you can add the bar resection with either a corrective osteotomy or a growth modulation. If you have the expectation that the angular deformity wouldn't correct spontaneously, if the deformity is more than 20 degrees, sometimes we can use the osteotomy to improve the exposure for the bar resection, like in this case. Like a central bar here, to have a supramalar osteotomy to reach the bar through the osteotomy to resect the bar. And the laryngoscope procedure or the resection of the bar in the central part, you can have the cortical window and through the burr and the dental mirror to be sure that you are excising the bar well and put the fat. The Jackson modification where you take up a triangular fragment, pre-drill it, and open this area. I think it's more aggressive to do this. You can use the ACL reamer to drill the bar. Use the scope, the dry scope, to be sure that all around you can have a physeal plate around. And the interposition, to use the adipose tissue. It's very common to get it from the gluteal region, bone cement, bone wax, the beak, cranioplast from the neurosurgery. But the trick is when you are using a tourniquet, when you deflate the tourniquet, the amount of bleeding coming will wash out this fat. So try to stitch it with a vicryl before doing this, not to wash it out and lose it. So the peripheral bar excites the periosteum. That's why when you have a slipped type 1 and you see like a very widening on the medial part of the epiphysis, try to open it to take off this periosteum because this will induce a bar in type 1. Use the high-speed burr, constant irrigation, use the C-arm, and remove 2 millimeters either side always. The challenges with visualization, use the headlight, use the navigation if you have a dental mirror. You can use the 3D print to print the bar to be cognitive how much the bar is to be resected. And a complication for sure, the reformation, infection, and displacement interposition. What about the literature? This is the first report in the laryngoscope, like 67 and 75, about the success of this procedure. But all the results seems that there is 84% of growth to the normal side, but 13% only didn't need further surgery. So this, the last note is the most important one, that even with the success, they have initial growth restoration in the first 18 months, and after this, there is a cessation. So when you are happy about your result, don't be happy because it will stop growth because it's not a normal epiphysis anymore. And as well for this study, 51 patients, at the end, 71% of those patients, they needed 2 additional surgery at the end. So let's start with those cases. So 6 years old, complex fracture distal femur, fixed with open reduction term fixation. 8 months, started to have genovalgum. So I think it was done well. They have like a Hoover fracture and fixed with 2 wires. And after this kid started to have this valgus, and this is amount of linear bar happening in the coronal and the sagittal here. So the plan was to do the Physeal resection. We're using the high-speed burr. I used the dye because it's a little bit tricky to know how much deep you are in, even with the illumination or whatever you are using. So start to inject the dye to reach how much you are deep. Use the marker. I use the marker only in the metaphysis part because I'm very anxious to put the wire or a marker inside the knee. And I put an 8 plate because I want to correct this. Is it going to succeed? I don't know, but I told to the parents. Second case, 8 years, ankle fracture 2 years back, varus ankle, and she had a peripheral bar with 1 centimeter leg length discrepancy. So this is the x-ray, ankle fracture being fixed with 2 wires after removal of the wire, and she developed the varus, a peripheral bar, this angle. So stop the deformity, because if I leave her, still she is 8 years, still having some growth, even for an ankle, and straighten the bone. I will deal later with the leg length discrepancy. So what I went to do supramallear osteotomy and put the correction for the distal tibia, and started to do the resection, the bar resection as well. And this is her x-ray. She's still doing fine. I don't know if she's going to maintain this correction or need a subsequent surgery. The last case, a 12-year-old girl, had 1 year post-menarche, slipped her radial epiphysis. She's a daughter of one of our colleagues. One of my friends, he did for her a closed reduction, so this is the x-ray. Very simple distal radius fracture. Hey, put the 2 wires just to be sure for the recommendation of for this kid, the 2 wires, and after he moved the wire, everything looks okay, and after a year, a complete arrest for the distal radius. She had a full range of motion. The options to lengthen the radius, so I choose to do the simple way. So I started to dealt with her as if I have a dislocated hip, which the head of the ulna is the dislocated hip. So I did a shortening for the ulna, and this is the amount of shortening. After the shortening, I started to drill the physis of the distal ulna, and this is after 6 months of her surgery. So again, what would be the biggest challenge in managing the physeal injury? Is it the early and accurate diagnosis, the timing and planning of the surgical intervention, the parental counseling and the limited surgical options, or the long-term follow-up and compliance? You answer it. Final remark, counsel the parents. Speak with them. Bar resection, tell them it's a 50-50 surgery. Stop, straight, and stretch. And early success doesn't mean that the lasting one of the bar is going to be in. And this is the reality, and this is the expectation of the parents. Thank you.